My name is Ivo Cerda, and I'm with Harvard Medical School. Today, I'll be presenting a video abstract for the American Journal of Public Health on our analytical essay titled Strategies for Naming and Addressing Structural Racism in Immigrant Mental Health. My co-authors are Anjeli Macaranas, Cindy Liu, and Justin Chen. Immigrants, here defined as foreign-born individuals living in the U.S., and their immediate family members make up 30% of the total U.S. population when considered together. This statistic reflects the fact that improving immigrant health will lead to improvements in the country's overall health. Now, over 80% of U.S. immigrants originate from either Latin America and the Caribbean or Asia, by far the two largest immigrant subgroups. On arrival to the U.S., individuals immigrating from these parts of the world are subject to racialization processes that result in the ascription of racialized minority identities, namely Asian and Latinx, Latina, or Latino, which hereafter will be referred to as Latinx. This racialization process, whether based on stereotyped external phenotypes or generalizations about the individual's culture, is scientifically unjustified, certainly. Yet it shapes the immigrant experience through frequent experiences of racial discrimination. Importantly, in an analogous manner to US-born individuals, Latinx and Asian immigrants are subject to not only interpersonal race-based discrimination, but also to the effects of structural racism. Here we define structural racism as, and I quote, the totality of ways in which societies foster race-based discrimination via mutually reinforcing systems, be it housing, education, employment, earnings, benefits, credit, media, healthcare, criminal justice, among others. This systematic discrimination becomes interwoven with underlying cultural, legal, and economic norms that reinforce exclusionary beliefs against racialized minorities, including Latinx and Asian immigrants. While subject to these significant stressors, Latinx and Asian immigrants experience disparities in mental health in the domains of both mental health care access and mental health outcomes. For example, Latinx and Asian immigrants are 40% less likely to use mental health services than their US-born counterparts. Much of the research on these disparities in immigrant mental health has focused on cultural factors like stigma surrounding mental health and specific illness beliefs among immigrant populations. Now, in addition to this, a growing body of literature has attempted to shed light on the mechanisms by which interpersonal racism, xenophobia, and social marginalization are internalized and negatively affect immigrant mental health. While these are extremely important efforts, the effects of structural racism on immigrant mental health have been largely understudied and underappreciated. Given the known effects of structural racism on the mental health of other racialized minorities, and also considering recent work on mechanisms linking structural racism to poor general health outcomes among immigrants, for example, most notably work by Supriya Mishra and colleagues out of the University of San Francisco State and New York University, we set out to characterize the role of institutionalized racism in contributing to poor mental health outcomes and access to mental health care among immigrants. So in a recent analytic essay for the American Journal of Public Health, through an exploration of the literature on Latinx and Asian immigrant mental health, we arrived at three major pathways by which structural racism contributes specifically to inequities in immigrant mental health outcomes and access to care. We then proposed strategies to develop and implement structural reforms to address these shortcomings, ameliorate stressors directly contributing to poor mental health outcomes, and eventually improve mental health care access and engagement among immigrant populations. Please note that although here we focused on Latinx and Asian immigrants due to their large share of their US immigrant populations, our findings likely generalized to other immigrant groups, particularly those that are subject to racialization processes like the one described above. So one of the main questions we set out to investigate was, how does structural racism contribute to disparities in immigrant mental health? And as mentioned earlier, we found three main mechanisms. One is anti-immigration policies, the other one is economic disinvestment and exploitation, and lastly, culturally insensitive mental health services. So starting with anti-immigration policies, federal policies regulate citizenship and immigration status and further determine the allocation of resources to subsidize state-level public coverage of immigrant populations. For example, the Personal Responsibility and Work Opportunity Reconciliation Act of 1996 introduced restrictions on the eligibility of non-citizens for federal public benefit programs, including Medicaid. A more recent example of an exclusionary policy at the federal level includes the now revoked 2019 public charge rule introduced by the Trump administration, which essentially qualified lawful receipt of public benefits, including Medicaid and Supplemental Nutrition Assistance Program, as a potential reason to deny permanent legal residency. By contrast, the DACA program was born out of federal policy seeking to protect the rights of particularly vulnerable immigrant subpopulations. And perhaps by ameliorating the effects of chronic stress associated with fear of deportation and increasing access to work-related health insurance, Latinx and Asian DACA beneficiaries exhibit fewer gaps in healthcare engagement and lower odds of depression relative to their non-eligible undocumented counterparts. On the other hand, within the limits set by federal guidelines, policies at the state level ultimately determine access to social services and benefits, including health insurance, government identification, and higher education. Exclusionary anti-immigration policy at the state level is perhaps best represented by omnibus immigration laws. These are essentially bills that regulate immigration through 3 or more provisions, including, for example, requiring law enforcement to verify immigration status during lawful stop, the so-called show me your paper laws. Other examples include penalizing the employment of undocumented immigrants and limiting immigrants' access to social services. Notably, this type of immigration laws have specifically been linked to poorer mental health outcomes among Latinx immigrants, irrespective of documentation status. Now, systemic racism encoded in federal and state level immigration policies seem to affect immigrant mental health through at least 2 general pathways. One is that policies limiting immigrants' access to public health insurance and other public health benefits affect immigrant mental health by restricting access to care. Examples here are many, but include a 5-year waiting ban imposed on most non-citizens eligible for Medicare and Children's Health Insurance Program. And other example includes DACA beneficiaries and undocumented immigrants being barred from purchasing insurance through the Affordable Care Act marketplace. These exclusionary policies force large segments of the immigrant population to rely on emergency Medicaid services and other emergency funds, likely increasing the broader societal cost of these policies. On the other hand, anti-immigration policies can enable and legitimize stressors that contribute to poor mental health outcomes among immigrants. For example, omnibus immigration laws are associated with increased fears of deportation, increased perceived discrimination, and feelings of lack of safety, not only among documented and undocumented immigrants, but also among US-born individuals belonging to racialized minorities. In fact, show me your paper laws seem to have a larger effect on mental health than provisions limiting access to social services among immigrants. Another key mechanistic pathway includes economic disinvestment and exploitation. Latinx individuals account for nearly half of the foreign-born labor force, whereas Asian immigrants make up about 1/4. But despite their labor contributions, immigrants continue to face structural racism in the form of labor exploitation, in part because of constrained job opportunities by immigration status. Immigrants disproportionately find themselves working in the most dangerous industries. Inadequate labor protection and ineffective pathways for demanding recourse, as reflected as reflected by the shortcomings in the enforcement of existing protective laws. And for example, how common it is for employers to report dissidents to U.S. Immigration and Customs Enforcement places immigrants in a vulnerable position in which their ability to remain in the country depends on a profoundly asymmetric relationship with their employer. This precarious situation rings true not only for undocumented immigrants, but also for immigrants on a working visa. Now, similar to anti-immigration policies, economic disinvestment and labor exploitation affects immigrant mental health likely by, first, restricting access to care, mainly in the form of diminished access to employment-based health insurance and an increased difficulty accessing providers, given especially long working hours and remote job locations. And second, by enabling and legitimizing stressors. A particular example of the latter pathway is the fear of deportation from workplace immigration raids, a practice specifically tied to adverse mental health outcomes among Latinx individuals, again, regardless of immigration status. Another key pathway involves culturally insensitive mental health services. And for both Latinx and Asian immigrants, limited English language proficiency has been consistently identified as a major barrier to access mental health services. As we all know, mental health is a domain of healthcare in which effective and empathetic communication and good clinical rapport with the provider are particularly important. While primary language concordance between provider and patient would be ideal in this setting, the use of professional interpreter services improves outcomes while reducing clinically significant errors. Now, despite federal guidelines requiring most healthcare programs and providers to offer meaningful language assistance services free of cost to their patients, the high cost of these services limit compliance with this requirement. Importantly as well, states are not required to reimburse providers for the cost of language services and are not required to claim available federal matching funds. Another important barrier to the effective use of mental health services by Latinx and Asian immigrants is the lack of knowledge among these communities regarding available resources. This lack of awareness likely reflects a lack of tailored outreach efforts and the inadequacy of at least some of these trial interventions, as well as the lack of immigrant representation at all levels of design and development of different interventions. Now, the other main question that we wanted to answer was, okay, how can we address structural racism in immigrant mental health? And we arrived at two general approaches, one being immigration, insurance, and economic reform, and the other one being a strong partnership with immigrant communities. So starting with immigration, insurance, and economic reform, it should be evident from the prevalent role of exclusionary policies elucidated through our analysis that policy reform aiming to facilitate the integration of immigrants into social services despite their immigration status would address several of the previously mentioned shortcomings. This reform should prioritize policy reform that expands insurance coverage. Potential examples include the following: expanding Medicaid coverage for mental health services, even if it is for emergency services to immigrant populations, including non-emergent but necessary outpatient mental health treatment. This should certainly include therapeutic interventions for acute yet non-life-threatening events. Policies incentivizing a shift towards increased use of preventative services, which is a general approach likely to increase cost effectiveness and decrease ethical burden placed on providers in the long run. Broadening access to affordable buy-in private insurance options should also be considered as a complementary tool to expand coverage for low-income documented immigrants. Offering public health insurance to immigrant children, on the other hand, consistently leads to higher service usage among this population. Notably, public assistance programs benefiting low-income children are thought to fully pay for themselves in the long run through increased tax collection. Immigrant labor law reforms aiming to defend the rights of immigrant workers should promote safe working environments and unequivocally guarantee protections from any form of retaliation if immigrant workers report abusive practices. And lastly, solutions that promote accessibility of existing psychological care among immigrants should be explored, with a particular focus in reducing costs of interpreting services and funding research that prioritizes immigrant participation at all stages, from priority setting to participation as subjects. Now, of course, culturally sensitive psychological interventions are more likely to be born out of close collaboration with immigrant communities, from needs identification to design and implementation. Two general collaborative approaches with proven efficacy in the global mental health setting with very high likelihood of working and addressing immigrant mental health include relying on strength-based paradigms and prioritizing task-sharing interventions. Strength-based programs are those in which community members and partners identify community-specific strengths that promote emotional wellness. Examples include psychoeducational efforts emphasizing community-level capacity to deal with stressors, among other examples. Task-sharing interventions involve training lay members of the target community to facilitate psychological support interventions. Such a strategy can help address shortages in the mental health provider workforce. And two examples that we explored included the Mental Health Gap Action Program, which aims to expand the mental health care capabilities of primary care physicians, improve mental health outcomes and care access for immigrants through essentially increased screening and early intervention. And the other one is Problem Management Plus, which involves training lay helpers to deliver brief trans-diagnostic interventions. So as a conclusion, the key pathways through which structural racism affects immigrant mental health include anti-immigration policy, economic exploitation, and culturally insensitive mental health services. And structural racism certainly leads to worse mental health outcomes, and importantly, locks out immigrants from needed treatment and resources. Addressing the effects of structural racism on immigrant mental health calls for immigration, economic, and insurance reform, as well as culturally adapted interventions based on collaboration with immigrant communities. This undertaking demands robust financial and political support for immigrant mental health. Thank you.